Now, I did have a PowerPoint presentation, but there's no screen and no laptop, so you're spared that. But if you want it to be sent to you, we can arrange, if you suffer insomnia, then we can arrange for it to be sent to you. I can show you the slides just in case. So there was the first one, and that was the title that Bert gave me, Coaxing Health Out of the Surgery. Okay. So yeah, when I received a letter from Bert saying would I give a short talk, I considered the title and I thought, well, I've been trying to do that for the last 27 years, so I thought it might be a good idea to find out what coaxing health out of the surgery actually looks like. Just a brief bit of background. I've lived in Truro for 33 years. I did my medical training at University College in London and my postgraduate training in Cornwall. I worked at Redruth Hospital, which is now a housing development, at Tiddy Hospital, which is also a housing development. I worked at City Hospital, which is a nice block of flats. I worked at Penzance Hospital, Trengreath Mental Health, and most of the time I spent at Trelisk. I joined the Lower Lemon Street Surgery, which, as Bert reminded me earlier on this evening, was better known as the bottom surgery. Now, that's not an anatomical reference, that's actually because it's at the lower end of Lemon Street. And one of the slides I was going to show you, actually, for those of you who don't know where the Lower Lemon Street Surgery, that was the Lower Lemon Street Surgery. And it's been a doctor's practice since 1806. And we did actually have a book written about the history of Lemon Street, so if you're interested, there's a little aside. It's actually fascinating to read actually what went on in medical care in those times. So that was 1806 to 2010, so that was just over 200 years. From 2010, we moved up the hill to the health park at the top of Infirmary Hill. So I started in 1991 as a partner, having been a trainee at that practice. So it took about 200 years for the practice to outgrow the premises in Lemon Street. And when I started, there were 6 partners. There was 1 part-time salaried doctor, there was 3 nurses, 1 practice manager, 1 secretary, and about 6 or 7 receptionists. Now, up the hill, we've actually got 8 partners, 7 salaried doctors, part-time, 4 nurses, 5 HCAs, practice manager, HR manager, office manager, 7 admin officers, and 16 receptionists, in addition to medical students and trainees. And in the last 8 years, we've now outgrown the new surgery. We're actually full there. So it just shows you how healthcare has expanded in recent times. So when I started in 1991, I had a patient list size of about 2,400 patients. Now my personal list size is about 2,200, and I'm probably twice as busy as I was then. So looking at the title, Coaxing Health Out of the Surgery, now I split that into two aspects, really both sides of the same coin, really. So first of all, coaxing health out of your surgery, or how to get the best out of your surgery, or coaxing your health out of the surgery, which is actually how to avoid the surgery. And I would actually aim for the latter, if I were you. So first of all, coaxing health out of your surgery. How to get the best out of the surgery? Well, there's quite a lot of challenges that we face. Increasing list sizes. So as you can see, the population of Truro is expanding. I'll show you this slide, because these are all the issues that we're faced with. And when I showed that to my wife, she said, well, that's very negative, isn't it? I said, well, I'll try and put some positive spin on. So increasing patient list size, well, that's good for commerce. So, although it actually means that we are much busier. The ageing population, well, of course, that has lots of health connotations, but good if you want to increase the Conservative voting. But on a more serious note, complex health needs, what we call multimorbidity. Now, lots of patients now have several health conditions that all impact on each other. Multimorbidity, people are living longer, they're getting more conditions, so it's multimorbidity. And transfer of work out of secondary care into general practice. So we now do a lot more in general practice that we never used to transfer it out. Lack of space, as I've mentioned, we've actually filled our cartilage on the health park. There is actually more space in there, so there's what we call expansion space. But it's actually easier to get a ticket for the Royal Wedding than it is to unlock any of the expansion space in the building. And if you want to know about the lift schemes, then I can certainly bore you to tears. So lack of space, there's access difficulties, parking. I don't know if you've ever tried to park at the health park. Yes, I can see lots of I see lots of people saying, yeah, nightmare. Yes, it's absolutely a nightmare. And we very frequently get messages on our screen to say, patients running late, they're stuck in the car park. And actually, it'd be easier for me to go onto the car park and do the consultation in the car park than it would be for them to wait to come in. So parking is an issue. Now, it's not surprising because we've got between the two surgeries, we've got 33,000 patients. So you can imagine that actually we're quite busy up there, which means that parking is difficult. And the bus, there's a single bus that goes up there. It's usually roughly every hour. It's a little hopper bus. And one of the big moans that patients had when we moved from down the lower Lemon Street up to the Infirmary Hill was actually all the buses used to stop in town and people used to be able to get a bus in. Now actually they've got to climb up Infirmary Hill. It's a good way of actually making sure they need to see the doctor because if you can't get up the hill, then that's an issue. But yeah, so public transport is certainly an issue that can access and impact health care. Under-resourced. Well, I mean, we work with community teams, our district nurses, the midwives, health visitors, they're all under-resourced. They quite often don't have enough staff to do the things that they need to do, and they can't provide the care necessary that's needed. So we're working with limited resources. We overspend our budget. And as you probably know, the Cornwall Health community is way over budget, which is an issue for the commissioning groups and also for secondary care. And there is a retention and recruitment issue. We advertised 3 times before we managed to secure a salaried doctor. And there is, in general, a recruitment issue around staffing medical services. So how does that impact on your experience at the surgery? And again, I actually just did a few little comments, and these come in very frequently. So I can't get through on the phone, so I'm sure you all have that experience. I can't always get an appointment. I have difficulty parking. My hospital appointment's not for months. Struggle to find carers for my elderly patients. My doctor's never there. I often hear that one. We get a lot of holiday. I'm on holiday this week, so all my patients will be saying I'm not there. Buses, consultations, and treatments that's not available. So all those issues actually impact. But just to give you a bit of a flavour, we'd have appointments from 7:30 in the morning up till 6 o'clock in the evening. We do between 800 and 1,000 face-to-face appointments per year. On a Monday, we take about 600 calls through to our switchboard, which is about 26% of our average calls. We take about 2,300 calls a year. So, I mean, we are busy up at the health park. So how can that change? So what are the factors that can actually make a difference to that? Well, there are a few. So the government is pushing the self-care agenda, and you may have heard about that through the media, and that's actually patients looking after themselves, having an idea about how to manage conditions, common conditions, either on their own or in partnership with their healthcare provider, because actually now much of the work we do is more patient-centred, and we try and actually say that this is the way a condition can be managed in joint consultation with patients. So that's a change from the old days where you just used to go to your doctor and he'd tell you what to do. So it's much more sort of patient focused. And there are lots of other ways of accessing healthcare. Pharmacy, for instance, have a great deal of expertise. They're a very useful resource. They can provide a lot of information around minor ailments. They can treat common conditions. So pharmacy is a very good resource. We have a practice website where you can actually give feedback and comment. We have an online service where you can use prescriptions, appointments, you can look at results. So all of these things are trying to actually empower people to say, okay, these are parts of my healthcare that I can actually take responsibility for, and then ease some of the pressure on the other systems. There's the expert patient program where some patients are actually focused into becoming experts in their own condition and actually help manage their own condition. We have a patient participation group which meets regularly and talks about issues that are affecting patients and what the surgery can do to try and address some of those issues. And then of course there's political pressure. speak to your counsellor about, you know, how your health is being affected by various issues. So that was really looking at that side of the coin, which is coaxing health out of your surgery. Now, the other side of the coin was actually coaxing your health out of surgery or avoiding the surgery. So what are some of the things that actually influence health? And having spent a little bit of time reading about that, there's quite a few things. So, and it's things that you will think about. So obesity, diabetes, education, exercise, drugs and alcohol, social isolation and loneliness, and social deprivation and poverty. And I was quite surprised, actually, when I looked at some of these things, what an impact that has on people's health. So, for instance, social deprivation and poverty, a BMA report from last year said that in England between 2009 and 2013, the difference in life expectancy for those in the most deprived areas compared to the least deprived areas for men was nearly 8 years, and for women was nearly 6 years. So if you live in the least deprived area, you're going to die on average 8 years sooner if you're a man, 6 years sooner if you're a woman, and that's from a very recent report. So social deprivation and poverty. Obesity, big issue. In 2015, 58% of women, 68% of men were either overweight or obese, and all the issues that go with that. And in 2015-16, there were over 500,000 admissions to NHS hospitals where obesity was a factor. Diabetes UK, from their recent survey, estimate that by 2025 there will be 5 million people in the UK with diabetes. In Cornwall, that figure for a population of about 470,000. Current estimates are about 6.3%. But again, for 2035, the estimate for Cornwall is going to be about 11%. Exercise, 26% of adults were classified as inactive, which is fewer than 30 minutes of physical activity a week, and unsurprisingly, inactivity levels rise with age. People who are on long-term unemployed who are never worked were most likely to be inactive, and that was 37%. Those with managerial, administrative or professional occupations were least likely to be inactive at about 17%. These are all statistics from the National Statistics Office on the gov.uk website. And inactivity has a direct link with health. The other thing that I found interesting and to a degree surprising was social isolation and loneliness. Now, people that are lonely or socially isolated more frequently use public services. And the estimates were about nearly twice as likely to visit a GP, 1.6 times as likely to visit A&E, more likely to have an emergency admission, and about 3.5 times more likely to enter local authority funded residential care. Well, of course, in the current economic climate we're in, actually, if you can avoid some of those funded places through schemes that actually aim to reduce social isolation and loneliness, actually it saves money. There was some research done by Holt and Lundstad in 2015, and he stated that weak social connections carry a health risk that is more harmful than not exercising, twice as harmful as obesity, is comparable to smoking 15 cigarettes a day. And specifically, people with suffering from social isolation are 3.5 times more likely to suffer from depression and twice as likely to develop dementia over the following 15 years. They're also more likely to be inactive, which can actually have their effect on their physical health, increasing their rate of stroke and heart disease. So that was, sat in my surgery, consulting. These are the things that you don't really think about. I have patients that I have identified that are socially isolated, but actually I haven't translated that into a direct effect on their physical health. So what can we do about that? Well, you'll be pleased to know there are some initiatives, and in Cornwall, actually the Living Well Cornwall, the Pathfinder project in Newquay, actually looked at identifying at-risk patients, and they had a program. It was a pilot that they set up, and they had a program looking at patients identified at higher risk, and they supported them through a program of motivational interviewing, assessing their needs, and then actually supplying those needs. And it often was someone just to talk to. It may have been some sort of physical activity, but all of those things had a major benefit on their health. And I think the well-being score that they reported was actually a 23% improvement, with an overall reduction in things like hospital admissions, GP visits, and overall health care. Social prescribing is another issue. Social prescribing, which I think you heard about a few weeks ago. I think Lindsay Southcombe, that's right, you had a chat about social prescribing. Now this is a means of enabling GPs, nurses and other primary care professionals to refer people to a range of local non-clinical services. Now for us as GPs it's really difficult to know what's out there. So if we have a patient that comes to us with a need, and actually it can be, there is someone out there in the voluntary sector, non-clinical sector who can actually provide those needs, that needs signposting. We don't know all of these things that are happening. So social prescribing is really about having a scheme whereby all these sort of activities are known, and they're usually non-medical. They're things like art activities, group learning, gardening, befriending, cookery, healthy eating advice, sports, activity, and those interventions are really good at preventing ill health. Primary care home is something you may have heard about. It's very topical at the moment, and it's basically a model that is to bringing together a range of health and social care professionals working together to provide enhanced, personalised and preventative care for their local community. So it's actually finding out what the needs of the community are, both health and social needs, and actually bringing that together under one umbrella, which will be input from GPs, from social services, from the voluntary sector, all working together. Multi-agency approaches to these is what's needed, because actually GPs are the worst at public health. They really are not good at actually signposting people to do these. We're very good if it requires a prescription. We're very good if it requires an active intervention, but actually for things like social prescribing, for the Pathfinder project, for living well, actually the voluntary agencies, care agencies are much better at actually delivering those services. Our input is to actually find the patients that would actually benefit from that. Yeah. And things like the Cornwall Health Promotion Service, which does a good job. I quite often refer patients to the Cornwall Health Promotion Service for their healthy weight programme, but they do all sorts of things with exercise, befriending, and lots of other sort of activities. So that's really what I had to say. I hope that's just about 20 minutes. My final slide was going to be, how can Trurra rise to the challenge, and what will Trurra healthcare look like in the future? And I did actually find a little cartoon, so I can just show you that. So that's the cartoon. So this is what will healthcare in Trurra look like in the future. And there it is. It's a pacemaker for your heart, plus you can download apps for your liver, kidney, lungs and pancreas. Thank you.